Banka Megha. She will be talking about OSSN.
Yeah.
Okay.
Imagine a farmer comes to you with a farming injury in your busy OPD and you treat it as a simple corneal ulcer, missing something far more sinister creeping right next to it. Good morning, class. I'm Dr. Banka Megha AJAY, and today we will learn about how to never miss an ocular surface squamous neoplasia. OSSN is the most common neoplasia of the ocular surface. It is a limbal stem cell disease and a clinical continuum of precancerous to cancerous epithelial lesions of the conjunctiva and cornea. With a diverse list of incriminating associations, it is usually unilateral. When bilateral, it is associated with HIV, immunosuppression, xeroderma pigmentosa, or palmoplantar keratoderma. OSSN, a disease of the conjunctiva, cornea, or both together, can present to us in one of its many forms. With this background of OSSN, let us approach this case of a 74-year-old farmer who presented with pain, redness, foreign body sensation in his left eye following a farming injury 1 month ago. He was treated with topical medications for the corneal ulcer at a nearby clinic. With no improvement and further deteriorating visual acuity, he was referred to our center as a suspected case of OSSN. On a closer look, we appreciate a brown corneal opacity with feathery margins, stromal hydration. Overhanging the temporal edge of the corneal opacity was a fleshy, gelatinous conjunctival elevation with multiple petechiae. The junction of the two lesions stained positively for rose Bengal. To further assess the inflamed, thickened conjunctival lesion, we checked for the 3 other hallmark signs of OSSN and noted surface keratin, increased intrinsic vascularity with prominent feeder vessels, and episcleral and corneal fixity. A corneal scraping of the ulcer confirmed dimetaceous fungal corneal ulcer, and there was significant clinical improvement within 3 weeks of topical medications. After clearance from the cornea consultant, we proceeded with complete surgical excision of OSSN with 4 mm clinically clear margins, alcohol-assisted keratoepitheliectomy with supplemental cryotherapy to bare sclera and the conjunctival edge, followed by careful ocular surface reconstruction with amniotic membrane graft. Don't be deceived by this beautifully healed ocular surface with no evident residual tumor or recurrence, as histopathology is king. It reported a positive base, and adjuvant therapy was planned in the form of secondary plaque brachytherapy. At 2 weeks post-plaque, our humble farmer is back at the farm with a visual acuity of 6'9". While OSSN is notorious to present as one of its many masquerades, especially corneal ulcer, OSSN coexisting with corneal ulcer is a rather rare case scenario, and literature recognizes it as a challenge with poor prognosis. However, we followed a methodical approach to control the active fungal ulcer, then proceeded with surgical excision of OSSN and further treated stromal invasion with secondary plaque brachytherapy. And at 6 months post-op, our patient is tumor-free. Be it an OSSN staring in your face, a masquerade, or coexisting pathologies, the holy grail to identify OSSN will never fail you. Once diagnosed, always assess depth using ASOCT or UBM, and when in doubt, always get an MRI for orbital extension. The gold standard treatment for OSSN has evolved from wide margin surgical excision to topical immunotherapy and plaque brachytherapy. Now, if you've slept for the last 3 minutes, here's your chance at redemption. OSSN is strictly a clinical term, not to be used for histopathology reporting to prevent misinterpretation. Always check for abnormally thickened limbal conjunctiva with all hallmarks of OSSN in its mimics. Never forget notes. When two pathologies coexist, always prioritize aggressive tumor control before any other surgical intervention to prevent intraocular or orbital spread, and always respect oncological principles. Thank you.
Very nice presentation, Dr. Banka.
Thank you, sir.
So in your case, would you like to consider for primary plaque brachytherapy after healing of this infection, or why surgical excision followed by the plaque brachytherapy? Which one you want to consider?
We would go for primary plaque brachytherapy in case we are sure about the base positivity with fixity. In this case, episcleral fixity.
Clinically, you have
Yes, exactly.
Scleral fixity was there.
Episcleral actually it moved over the conjunctival part of it moved, but we noted stromal invasion intraoperatively. So we thought we could just wait for histopathology confirmation, and then we could go ahead with secondary plaque brachytherapy. But in either cases, primary plaque brachytherapy is just as good if we are sure about our clinical judgment.
Thank you.
Thank you, sir.